Hi everyone. So today we're going to talk about point of care gallbladder ultrasound. So this is a little bit different from your comprehensive right upper quadrant ultrasound through radiology in which you're examining all structures right upper quadrant, but today we're focusing in on the gallbladder. So we know that biliary disease is pretty common. It affects 8% of men and 17% of women each year, leading to more than 600,000 surgeries each year. Cholecystitis is an emergent surgical condition. When we're talking about right upper quadrant pain, your gallbladder pain, your biliary pain may radiate to the right scapula, and so sometimes patients will feel that first and they'll come in complaining of a nagging back pain, if you will. They may or may not have nausea or vomiting, so you have to maintain a high index of suspicion for gallbladder disease. For cholecystitis, so up to 1/3 of patients may not have fever or leukocytosis. 90% though will have a positive Murphy's sign. Ultrasound is actually the first choice in imaging. I know that so many people want to jump to CT when it comes to abdominal pain complaints, but think about what you use on your differential, and if biliary or liver is the first concern, then consider ultrasound because ultrasound is really the best choice for gallbladder imaging. Ultrasound for cholecystitis is 88% sensitive and 80% specific. If you have a negative ultrasound with a high clinical suspicion, then you might turn to your HIDA scan. So when we're talking about gallbladder anatomy, the gallbladder itself lies on the visceral surface of the liver between the caudate and the right hepatic lobe. The gallbladder fundus, which we always want to make sure that we visualize on ultrasound, it contacts the anterior abdominal wall. The gallbladder body then tapers into the neck and then becomes a cystic duct. The cystic duct joins the common hepatic duct to create the common bile duct, and the common bile duct runs right next to the hepatic artery and the portal vein. So when you're looking at the common bile duct on ultrasound, it'll look like it runs just on top of the portal vein. So how do we get started? I should back up and say, like any other abdominal organ, we are going to want to use a low frequency ultrasound probe. So either your curvilinear probe or your phased array probe, and curvilinear is really going to be the best for this if you have a curvilinear probe. So when we start scanning the gallbladder on your patient, one of the first things we can do is use a subcostal sweep. So with this, I'm going to place my probe in a longitudinal orientation. I'm going to start in the subxiphoid area, aiming the beam inferiorly or towards the patient's back. Probe marker is to the head, and I'm going to sweep inferiorly and laterally along the costal margin and see if my gallbladder kind of pops into view. Another approach, and this is really over the ribs, so it's an intercostal window, if you will, the X-7 approach. So I'm going to start again at the xiphoid process, then I'm moving the probe over the ribs right 7 centimeters laterally. So I'm moving it to the patient's right over their ribs to mid-clavicular line or just beyond. And so this is your intercostal window. So you can move the probe laterally to scan through the liver and look for your gallbladder in this position. And this can work really well with some patients that might be having a lot of abdominal pain because you're not putting that pressure on their abdomen. And then finally, we have the flattening the probe approach. I really like this in thinner, younger patients or even pediatric patients. So we're going to start with the probe in the subcostal position. Probe marker to the patient's right, and of course we're on the right side. Then I'm going to have the probe straight up and down, and I just start flattening the probe or dropping the angle of the handle so that it flattens out. So I'm going to, as I drop the probe, I'm going to look for the patient's right kidney, and then anteriorly to that, I should see the patient's gallbladder. We're going to fan the beam anterior to posterior. Once I have my gallbladder in view, depending on which approach I'm using, I want to look at the sagittal gallbladder and the transverse gallbladder. And I'm trying to go a little more in plane of the gallbladder, not necessarily in plane of the patient. So right here, I'm seeing the gallbladder. If you look closely, you can see the patient's diaphragm. This is with the probe marker pointing to their head. Their liver, I'm seeing the gallbladder, and somebody's measured the gallbladder wall right here, and now I'm seeing the portal triad. Then I'm going to turn the probe with the probe marker heading towards the patient's right to get a transverse view of the gallbladder. And then I want to come in and identify my portal triad. So right here, I'm looking for the portal vein, which should be your bigger structure. And then I'm looking for your common bile duct and the hepatic artery, which should form something that looks a little bit like a big Mickey Mouse face with Mickey Mouse ears. So when we're talking about the common bile duct, we want to make sure that we look for that every time we do a gallbladder ultrasound. So it lies anterior to the portal vein in the long axis. So what that means is when we're looking at an ultrasound video clip or ultrasound image on the screen, it's going to look like it appears on top of the portal vein. That's going to be an important relationship to remember. We should also not see flow through the common bile duct. We'll see flow through the hepatic artery, we'll see color flow through the portal vein, but not through the common bile duct. We want to measure the common bile duct, and so your normal common bile duct is going to be 4 millimeters or less, but we can give it up to a millimeter for every decade after 40. So if I have a 70-year-old coming in and they have a common bile duct of 7, then I'm not as worried as if I see maybe a 20-year-old with a common bile duct of 8. The other measurement we want to get is the gallbladder wall thickness. So your normal gallbladder wall thickness is less than 3 millimeters. We want to make sure that we measure the anterior wall. And why do we want to do that? Well, if you go all the way back to that physics lecture, I know everybody's groaning, why? Were physics ever important? Actually, this is why. So we have that posterior acoustic enhancement, which makes the far side of the gallbladder, the far field, appear really bright white. And it's really difficult to determine what's wall and what's just posterior acoustic enhancement. So getting the anterior or maybe anterior lateral wall here and the transverse position is going to give you the best wall measurement. So what are some of the things that we are looking for when we are doing an ultrasound of the gallbladder? Well, one of the first things that we're looking for is going to be, yes, stones, gallbladder stones, cholelithiasis. So these stones are going to be bright white. They'll be a bright white, hyperechoic focus with acoustic shadowing. However, not all stones will shadow. Really small stones, like 3 millimeters smaller, they aren't necessarily going to shadow, but if you have a bunch of them together, they can certainly shadow. Gallstones will move with the patient. You can have a lot of little teeny stones, like a collection of really small stones, or you might have one really big stone. So you want to make sure that you're looking for stones and you're determining where the stones are. Are the stones in the fundus of the gallbladder? Or has there been one big stone that's come down and is sitting right in the neck of the gallbladder? Something else that we look for, this gets actually pretty tricky, is this is cholelithiasis. Everybody is looking for the gallbladder, I know. So this is something we call wall echo shadow or wall echo shadow sign. So we're not seeing the gallbladder right here because we're not seeing the lumen of the gallbladder. If you look from top to bottom, we're seeing the liver here. We're seeing bright white and then shadow. So we're seeing liver, then we're seeing bright white of the gallbladder wall, and the stone is right up against that, so we're not seeing any lumen. We are seeing then just the shadowing of the stone. So be careful and always look for that if you're having trouble seeing a nice gallbladder lumen or fundus of the gallbladder. Then we look for cholecystitis. So this is inflammation of the gallbladder, and it's usually caused by biliary duct obstruction, which is a setup for infection. So your ultrasound findings may include gallbladder wall thickness, so greater than 3 millimeters, stones. You don't necessarily have to have stones though. You might also see pericholecystic fluid. So we know that fluid is black on the ultrasound, so you're looking for black fluid on the outside of the gallbladder. So note in this video how thick the wall appears. It's just really thick, and then we see a bunch of stones with shadowing. If you look closely, you might even see a little bit of pericholecystic fluid. So two big caveats when looking at this ultrasound. So somebody who's recently eaten and has a contracted gallbladder, their wall might be a little bit thicker. And also somebody who has ascites, they're going to have pericholecystic fluid because, well, they have ascites. They have fluid throughout their abdomen. So just be careful. So two more examples of cholecystitis. Here we can see these are just your still shots. Right here we're seeing a really thick wall and all of that stone and shadowing, and if you look closely, maybe a hair of pericholecystic fluid. And then we actually have the wall measured. I realize that it may not be the best measurement, but at the thickest point, and it's 10 millimeters. So that's just a really, really, really thick wall, and combined with all other factors, this patient has cholecystitis. Next, we're going to look for our common bile duct. So now we're scanning down to the portal triad. So I always really like to make sure I have a nice view of the gallbladder and the sagittal plane. It looks like, you know, the long part of an exclamation point, and then your portal triad should be the point or the dot to your exclamation point. And then once I identify the portal vein in that view, I like to make sure I rotate to the long axis and get a really nice view of the common bile duct. Unfortunately, I'm not showing you exactly how we did that here, but if you look closely, we're seeing the portal vein with flow and then a really dilated lumen right on top of it or anterior to it without any flow, and that's your common bile duct. So this one is huge right here. So normally the common bile duct is 4 millimeters, and that's inner wall to inner wall, so very small. Right here we're seeing this, actually there's a name for this. So if we look closely, we're seeing the portal vein and then the common bile duct right on top of it, and they look about the same size, or the common bile duct actually looks a little bit bigger here, and that's something we call the double barrel sign. So when your common bile duct is so dilated that it's the same size or bigger to your portal vein, it is what we call the common bile duct, and then you're concerned about an obstruction within the common bile duct, so just distal to where we're seeing that. So those are some things that you really want to make sure that you're looking out for with your point of care gallbladder ultrasound. Some other interesting things. So this is something that's not really pathologic, but just really more interesting. Some people have this. It's called a Phrygian cap. It's when the gallbladder kind of doubles back on itself. And so if you all remember the gnomes that have the folded over hat, so that is a Phrygian cap. And so the gallbladder folds back on itself almost like a little gnome's cap. So if you look through here, you can kind of appreciate in the right upper portion of the screen how that gallbladder appears to be folded back on itself. And here's just a still clip of it. We can't really appreciate it well here. You can a little bit, but it's just a folded over gnome's hat gallbladder. That is not pathologic. It is just a finding in some people, but a little bit more fun finding. Another ultrasound finding that you might see is going to be the gallbladder polyp. So a polyp is different from a stone, so it is not mobile. It's not going to move whenever you have the patient roll into the left lateral decubitus position, but it's fixed to the wall. And so you can see here as we go through the video, in the sort of upper portion of the fundus of the gallbladder, there is a hyperechoic to medium echo structure right there, which is attached to the wall. So that's a gallbladder polyp. And beyond the scope of this lecture today, but it's a finding. So when gallbladder polyps, some are benign and then some are malignant, and they're different findings in malignant polyps, including size compared to benign findings. So this is something that I would have sent to get a comprehensive ultrasound exam done, but it is a finding that you might see when you're doing gallbladder ultrasounds. And then finally, gallbladder tumors. And so, less common than stones, certainly, but you might occasionally come across these. And so, like the other, like the renal tumors or the bladder tumors, so they are irregular. So, we're seeing this, and there's a non-specific wall thickening, a mass that does not move with the patient, might have different echoes within it. It may grow so big that it appears to replace the gallbladder, if you will. So we can see here a gallbladder tumor. It's different from stones. There might be some calcifications that have some shadowing, but non-specific wall thickening, irregularly shaped mass that can eventually replace the gallbladder. So that's it, folks. We've had a little bit of discussion about gallbladder ultrasound and some of the big things that we look for when doing a right upper quadrant or gallbladder ultrasound, just a point of care ultrasound. As always, you can email me with any questions and continue scanning.